Hello everyone, this is Gina Herrera and I am presenting the lecture Antepartum or Prenatal Testing. Let's start off with prenatal labs. Whenever you're a patient, an OB patient, there's a series of prenatal labs that are done along with other tests that might be necessary, but the doctors will take, it seems like, 1 million tubes of blood, but it's prenatal labs that are required, and sometimes they'll repeat these labs toward the end of the pregnancy just to make sure things are still okay. The CBC is one lab, the rubella. They'll do a pap smear, possibly, and they may even do cultures, cervical cultures, just to make sure there's no STIs. The Group B strep is done, but this is done not so much at the beginning, but it's done at 36 weeks gestation. And they're doing a culture to see if the baby could be at harm's way. If they test positive and they're going to be in labor, they'll give them antibiotics, usually it's penicillin G, during the labor process. Just like if you have a beta strep infection and you go to the dentist and you have a strep infection that caused some heart issues, they would give you antibiotics. But this is Group B strep that's done at 36 weeks, and it's a rectal swab, and they test again for the beta strep streptococcus infection. Sometimes when I say if they know that they're going to be a planned C-section, they won't do this because they feel that they're going to get prophylactic antibiotics for the surgery anyway. So some doctors choose to, not do this test. Glucose tolerance test. This is done usually around 28 weeks, and that's a whole nother lecture with diabetes, but they do test for that gestational diabetes later in the pregnancy, around 28 weeks gestation. Type and screen is done, a urinalysis. These are some of those cultures that might be done, a GC or chlamydia. The other ones that might have been done, they're checking for trichomonas or any other STIs that could show up. And HIV. And again, they will do these tests at the beginning, and sometimes, the ones that they do at the beginning, they'll do at the end when it's time for the patient to deliver. So when we talk about prenatal testing, we're assessing fetal well-being. How well is this fetus doing, surviving in utero? There's two major goals for antenatal testing: identifying the fetuses at risk and identifying appropriately oxygenated fetuses. So when we identify fetuses at risk, we're looking at acute or chronic interruption of oxygen being an issue. So we want to assess for that to prevent permanent injury or death. The second goal, identifying appropriately oxygenated fetuses. We do this so that unnecessary intervention can be avoided. We usually start monitoring around 32 to 34 weeks gestation, and this continues till birth. And sometimes it's monitoring to be on the lookout for problems that could cause the hypoxia to the fetus. Some disease processes can predispose the patient to have issues with perfusion to the baby. That might be like your diabetes, it might be like your hypertension, or any other things that could cause some hypoxia to the newborn. So that's why we want to assess this fetal well-being. Again, some pregnancies at risk. not just disease processes, but pregnancies that go past 42 weeks, actually, that's very risky. Remember, everything has a lifespan. The placenta also has a lifespan. So if they go over their due date, every week over the due date can put the baby in jeopardy because the placenta starts to break down. It ages. It can be calcified. It can be, have some issues with providing the nutrients as well as the oxygen to the baby. Multiple gestation, having more than one. So they're high risk because they have two babies, not just one. Prior preterm birth, if they've delivered preterm deliveries prior, they may be at risk to do that again. So that would put them at risk. A previous pregnancy loss before 20 weeks or diagnosed cervical insufficiency. So the cervix may not be, I guess you could say, it may not work to do, usually we say incompetent cervix. That's a cervix that may not hold up or it may start to dilate, and that would cause a loss possibly prior to 20 weeks gestation or even prior to the due date. If a cervix starts to dilate on a premature patient, that would be in that premature range. Remember we said after 20 weeks all the way to the end of that 36th, 37th week was considered preterm. We would look at that. Some other things that would put the mom at risk would be the maternal age. If she's younger than 16 years of age or even greater than 35 years of age, that's kind of like a risky age limit right there, range. As you know, women are they're more career oriented, or they are having babies actually a little later than they were in the past. So it's not unlikely that we have patients that are over 35 years old delivering babies. Do they have issues? Some do, some don't. Most don't. It's again, the prenatal care, keeping up with everything is really important. Some chronic maternal conditions, we talked about that. I'm sorry. Some chronic conditions we talked about were the diabetes. If they have diabetes, type 1, type 2, or they are gestational, if they have issues with hypertension or cardiac disease, anything that could affect the perfusion of oxygen to the fetus. RH isoimmunization. So again, if you have a baby and or you're pregnant and you're a RH negative, then you would definitely need some RhoGAM. So especially on moms that deliver within 72 hours, they will get RhoGAM before they go home. And this is to protect them with the pregnancy following their delivery. So that would be the next pregnancy. So it's called RH isoimmunization that we're dealing with. The maternal history of unexplained stillbirth. So we don't know why after 20 weeks she delivers this baby and the baby is not alive. So it could be an accident in the uterus, inside the uterus. Sometimes the cord gets twisted, and again, there's decreased perfusion to the baby for oxygen. But sometimes it's just unexplained. We don't know why. And then suspected intrauterine growth restriction, IUGR. You might see me talk about IUGR. And that is, again, the baby's not getting what it needs to grow healthy in utero. So it has some growth restrictions. And that puts them at risk. And their fetal well-being is at risk. So those are just some things. So what can we do? Maternal assessment of fetal activity. Well, if babies are moving around, they're pretty healthy. So we have a thing called a daily fetal movement count or a kick count. So Fetuses spend about 25% of their time making gross body movements. They have periodic sleep cycles, but for the most part, they're constantly moving around. When I say movement, that could be movement of a finger or it could be a huge kick. It varies. So, again, they are constantly moving around. Part of the biophysical assessment includes the daily kick counts or fetal movement count. It's non-invasive, inexpensive, and doesn't interfere with the daily routine that's frequently used. It's frequently used, especially in pregnancies complicated by conditions that may affect their oxygenation levels. So this, again, it can be done at home. It's called a daily fetal movement count or a kick count. So it might be done once a day for 60 minutes or until 10 movements are counted. It could be done 2 to 3 times a day for 2 hours or until 10 movements are counted. There's no standard definition, but we know fewer than 10 movements in a 2 to 3 hour period is less than usual. A count of less than 3 in 1 hour needs further evaluation, and they'll do an NST, a CST, or an ultrasound. So those are just some other tests that I'm going to cover in this lecture that you might see. So further testing would be conducted if there was an issue. Movements are not typically present during sleep cycles, which can last approximately 20 minutes. It could decrease if there's the patient's on some type of medications or using substances like antidepressants, alcohol, smoking, taking narcotics, and including methadone. These are things that could directly affect the fetal movement. Movement doesn't increase nearing term because, as you know, the baby grows and there's limited space to move a whole lot. So it gets really tight in there. That's why we tell people if your baby's breech, if it's not head down, and you're like 38 weeks, it's very unlikely the baby can move and flip again to be, head down. So movement doesn't increase nearing term. If anything, it's limited. Obesity can decrease the perception of fetal movement. So if you have a really obese patient, she may not feel the movement like normal. Because of the fat around that area. Fetal movement does provide reassurance of fetal well-being. So we know if our babies are moving, that's a sign that they're doing okay. All right. Some maternal teaching for fetal activity. The first movement is usually, again, we talked about this in the other lecture, is felt around 18 weeks, but it is recommended to do the kick count beginning at 28 weeks since fetal movement is harder to identify. Again, at 28 weeks, it's a lot easier to feel the movement than at 18 weeks. You want to explain a procedure for counting, and that would be like a daily record we're going to use, counting at the same time each day, approximately 1 hour after a meal is usually an ideal time to do it. You want them to lie quietly in a side-lying position. And when they would contact the provider. So if you refer to page 141, there's a labeled patient education kick count instruction table that would be provided. Or actually it might be just in the chapter. But you can refer to page 141. And that kind of goes into a little bit more of, when to contact the provider, goes over the kick count and how it's conducted. Ultrasound is also another prenatal test that the patient may experience during pregnancy. Again, we talked about this last lecture, the transabdominal ultrasound and the transvaginal ultrasound. So as you know, the transabdominal we use later in pregnancy. That's where there's a transducer that passes over the abdomen. And what happens is it's better if the patient has a full bladder for this because it will actually, the full bladder pushes the uterus up further so it's easier to view. With transvaginal, it's the patient's prepped as for a pelvic exam, and they insert that vaginal probe with a condom to view through the vagina, and that would be earlier in the pregnancy where there's very, very slim chance of seeing anything through the abdomen. We go in with the transvaginal ultrasound. Know that ultrasounds, intermittent ultrasonic waves, form images for us to view the fetus. It's non-invasive, painless, non-radiating. There's no known harmful effects to either the woman or the fetus. It could be four-dimensional. They used to have three-dimensional, and now they're getting really sophisticated. You can almost see the baby's face and the features, and they look exactly like they would in person. It's just that so perfected. And they just keep getting better and better with it. Sound frequency is used to create a pictorial image, and it can be performed, again, abdominally or transvaginally. So we're looking at fetal activity, things that you look at on an ultrasound when you're looking at fetal well-being. The activity, is the baby moving? You look at their organs. Fetal and placental anatomy, is the placenta perfusing? And they can do some velocity tests to see, if they are getting perfusion from the placenta. You can look for gestational age because they're going to be measuring the baby, the limbs, and the baby in general gets measured. They measure it through the ultrasound image. And we determine, is this baby normal versus abnormal growth, to see if, everything is growing and doing okay. So, ultrasound. Here's an ultrasound. This is just a regular ultrasound, nothing fancy. But we do have some really, really sophisticated ultrasounds. What's the benefit of the transvaginal ultrasound? That's transabdominal. That's the transducer. Okay, and remember that transducer passes over the abdomen. It's really hard to see, early in the pregnancy. The later that you do this type of ultrasound, the better viewing. And of course, you want a full bladder. Here's the transvaginal. It's covered with a condom. It's inserted through the vagina, and the images bounce off the vaginal canal and portray an image. So the benefits: early identification of pregnancy for the transvaginal one, observation of fetal heartbeat, breathing movements. You can identify more than one embryo or fetus early in pregnancy. And then you can assess, again, the fetal well-being. We can look at number, size, location of the gestational sac early in the pregnancy, presence of fetal, cardiac, and body movements, any uterine abnormalities. That would be if the patient had issues with the uterus, if it had some growths on it. And then in general, just for ultrasound in general, not just transvaginal, it helps with looking at fetal positioning. Gestational age can be determined, the growth pattern of the fetus. If there's any abnormalities, we can do an AFI, which is amniotic fluid index, and that's measuring pockets of the amniotic fluid around the baby. Remember that fluid around the baby is important because it keeps the baby healthy, and it keeps the baby floating in the uterus. And you want to have enough fluid. So we're looking at the fluid, and we can measure the pockets of fluid. The placenta, the condition and the location. Is it growing? Is it where it needs to be in accordance to providing the oxygenated nutrients? And then, of course, we can look at the cervical length with ultrasound, just to check and see if somebody's got issues having premature labor, their cervix dilates early in the pregnancy. We can also assess the cervix. All right. So the biophysical profile, and this is a comprehensive assessment. It includes 5 variables: the breathing movements, fetal breathing, the fetal movements, the fetal tone. We just talked about the amniotic fluid volume, or AFI, amniotic fluid index. We can look at the fetal heart rate if they're having accelerations with activity, which would be considered a reactive NST, and we're going to talk about the NST in just a second. Each thing is scored 2 for normal and 0 for abnormal, okay? So it really can reflect, it's indicated for things, again, or status with the patient that could impede the fetal well-being, diseases, or, they're going over their due date, so we want to watch them, so we may do some certain tests just to make sure that the baby is still getting perfused with oxygenated blood supply. Just because it's the due date, not every doctor is going to jump on board and say, okay, it's the due date, you're not delivered, so let's deliver you today. Some doctors will let the patient go past the due date. Not hopefully dangerously past the due date, but it's not unlikely, especially first-time pregnant patients. Their babies sometimes don't come, on time. They may go over the due date, but most doctors, especially, they're just itching to induce these patients, and know that inductions that occur prior to 39 weeks gestation require a diagnosis of some sort. They can't just induce people prior to 39 weeks. They have to have a reason, have to have a medical reason. Okay. So the biophysical profile is usually conducted over a 30-minute time period. And each of the 5 biophysical profile components are assigned, again, a score of a 2 for normal or present and 0 for abnormal. A score of an 8 to 10 is reassuring, whereas a score of a 6 is considered equivocal, and the test should be repeated within 24 hours if it is done on a preterm infant, or in the case of a term infant, if it's 6 or less, then you would have immediate delivery. That would be suggested. So, again, you don't want to leave a baby in utero that's not getting proper perfusion, or it's getting oxygen. So we need to deliver that baby if it's term. All right. So a score of 0 to a 4 out of 10 strongly suggests fetal asphyxia and indicates a need for consideration for early or immediate delivery. So we got to look at that. Refer to table 6-4 on page 178. That explains how each component for the BPP is actually scored. So it goes over the BPP scoring in depth in that table. Also, table 6-5 on page 178 reviews selected indications for non-stress testing with the biophysical profile. So again, that's the NST, which we're going to talk about in just a second. The non-stress test, or the NST. So this is looking at, we put mom on a monitor. We give her a little button to press. When she feels the baby move, she presses and it marks a little marker on the fetal monitoring strip. So this is done with the big fetal monitor at the bedside. So if it's reactive, that is the preferred result we like to see. That's greater than or equal to 2 accelerations, peaking at least 15 beats per minute above the baseline for 15 seconds in a time frame of 20 to 40 minutes. Okay, so a baseline. So when you put mom on a monitor, you got to get a baseline. Remember, we said 110 to 160 is a normal fetal heart rate. So if my baseline would be, say, 120, then when I'm doing this, in order for it to be reactive, I need it to be at least 15 beats above the baseline, lasting at least 15 seconds. And this has to occur within 20 to 40 minutes. That's how long the test usually would take, the NST. Now, say it's 20 minutes, say it's 25 minutes go by, and you see greater than or equal to 2 accelerations that are lasting at least 15 beats above the baseline for 15 seconds. Say that first 25 minutes, you see 3 of them, okay? Then you're done. You don't have to keep them on the monitor for 40 minutes. We just say as long, it could take up to 40 minutes to occur. So a reactive is the desired result. Again, you got to find out the baseline to determine if there are any accelerations. And then the little boxes have time, the little boxes are 10 seconds, and there's 6 little boxes on the strip. And, you'll see what I'm talking about in a second. But it has to last at least 15 seconds. And again, that would be reactive. Non-reactive is absence of required characteristics for reactive test after a 40-minute period. So that's no accelerations, or they may have, it looks like an acceleration, but it's not because it's not lasting long enough. But a non-reactive is the undesired effect. So as you can see, this is reactive. So if you look at this strip, one bold line to the other is a full minute, because those little bitty squares in between are 10 seconds each. So can you see when mom pressed the button, the little arrows showed up on the heart rate? And you can see where she had an so it looks like this mom's baseline is like 140. So if it goes up to 158, which it looks like, well, actually it went up to 158. That was an acceleration because, again, it went at least 15 beats above the baseline. It's got to last at least a square and a half. Those little bitty squares, that's 15 seconds because each little square is 10 seconds each. And as you can see, this baby's reactive within the first 5 minutes. You can see the baby has had, it's got to be 2 equal to or greater than 2 A cells in a 20 or 4 to all the way up to a 40-minute time span. So, like I said, if the baby meets the requirements and it's not up to 40 minutes, then the test is over. You can take them off the monitor. But we got to leave them at least on 40 minutes to determine if it's not reactive yet. And then, of course, we'll take action depending on what the result is. So that's reactive. You can see where mom presses the button, the little arrows show up, and it definitely is conjuncted in conjunction with fetal movement. This is non-reactive. So you can see the baseline here is about 140, but this baby's not having any accelerations at all, and they're not there at all. And it's not even if it's just 1. But this would be non-reactive. So this baby here is telling us something's not right. They're not getting oxygenation, perfusion, something's going on. Okay, so our diabetic moms, I can remember being on the labor and delivery unit, and sometimes they would send them to the prenatal testing area around our unit. And we had a diabetic mom or somebody with hypertension, and they would get these done twice a week toward the end of the pregnancy, like maybe the last 3 or 4 weeks, just to make sure that the baby was doing okay, although, they had the disease process, just to make sure that the baby is doing okay. And if the baby's not, then we probably have to deliver the baby. So, but it's non-invasive, the NST. Again, it can take very little time, or it can take up to 40 minutes. It just depends on what's going on with that strip. But the desired result is reactive, and non-reactive is the undesired effect or result. So say the baby's in a sleep cycle, because sometimes our babies go in and out of sleep cycles. There's a little doodad called a fetal acoustic stimulator, and it makes an obnoxious noise, and that little disc will vibrate if you press a button. It's like a little, a little device that they can use. Sometimes if we want to speed the test up a little bit, we can put that on mom's abdomen and press the button, and the baby will be bouncing off the walls. It doesn't like it. So the baby can hear it, and it sometimes can wake the baby up enough that we can proceed with the test. But yeah, it's called a fetal acoustic stimulator, and you want to go close to the baby's head with it, because again, they can hear it, and they can sense it. So that's where you want to be with this fetal acoustic stimulator. You want to go as close as you can to the baby's head. The other test that we're going to talk about, another test, is the contraction stress test, okay, or the CST. You may hear me refer to it as a CST, okay. CST is evaluating the functioning of the placenta. So we're looking at the placenta to see if it's supplying enough oxygen and nutrients to the growing fetus. It's a means of evaluating the oxygen and carbon dioxide exchange of the placenta. We're looking to see if the fetus is at risk for intrauterine asphyxia by observing the response of the fetal heart rate to the stress of uterine contractions. So spontaneously we can make these occur, or induced. We're looking at the contractions and the effect on the baby and its heart rate. The test is usually conducted by obtaining a baseline fetal heart rate for like 20 minutes. If spontaneous uterine contractions do not occur during this time, we can do uterine stimulation by hanging a bag of IV oxytocin to create those contractions. Mom also can do nipple stimulation. If they stimulate or rub the nipples, it causes the uterus to contract and the body releases oxytocin. So, we can make those contractions happen. If the patient's not in labor to do this test, we can definitely create contractions to do it, to see if the baby is tolerating the contractions and their heart rate is stable. So we're looking at the CST. It's a critical component to see, again, if that placenta is functioning. We use an electronic fetal monitor to do this test. And the results are either negative, positive, equivocal, or unsatisfactory. Okay. So if you look at this is normal, which is negative. So again, this is kind of tricky because it's the opposite of the NST. A normal result is the negative CST, and that is the desired result. Okay, and as you can see, there's no issues. Mom is having contractions. Those are contractions on the bottom of the strip, those little mountains. And even though she's having contractions, the baby's heart rate is stable. There's no decelerations or drop in the heart rate. So here's some other results. So negative, again, the baby's heart rate is staying stable. And that's the desired effect, the negative CST. The positive CST, you can see where there's a dip in the heart rate. That bottom left-hand strip is the positive CST. That is the undesired effect. We don't want to see that. That's telling us that this baby is having some fetal distress and the contractions are putting them in a hypoxic state. Suspicious CST, or actually it can be called equivocal. That's another name for it. The result indicates the presence of either intermittent late decelerations or significant variable decels. So we're going to talk about the types of decelerations. But you can see with the suspicious or equivocal, there's not enough really going on to determine if it's positive or negative. We do see one D cell there, okay? It's equivocal or suspicious. And, you know, again, we need to more information to determine. So it's, you know, that's what it's classified as. Unsatisfactory, we no longer use this, so that don't worry about that one. It's not really classified in your textbook. I know some books do still use it, but that would be, as you can see, the heart rate broke up, and you can't even tell if there's any A cells, D cells, nothing. So that would be unsatisfactory. But some books are including it, and your book actually is not. So I'm just going with negative, positive, or suspicious, or equivocal / equivocal. And again, you know, these are just types of CST interpretations. But if you just know that the negative is the desired effect, and the positive, of course, is undesired. It's letting us know that this baby is having some hypoxia, that it cannot withstand these uterine contractions. So a CST, a contraction stress test, it's not for everybody. There's some patients that it's contraindicated, and that's a patient with preterm labor or who are at risk for preterm labor. So why would you want to create contractions and stir up stuff to put them at risk if, you know, they're at risk for preterm labor? Because it can put them in labor. We can kick them into a labor pattern that maybe we can't stop. So we don't definitely want to put our baby in jeopardy by creating contractions for the CST and putting them into preterm labor, the mom. Somebody that also has an extensive history of uterine surgeries or a classic uterine incision from a prior cesarean birth. So uterine surgeries, that's when they're cutting open the uterus, or they're removing tumors, or they're cutting open the uterus with a classic incision. So there's different types of incisions. This would be the classic one. It's the big one that goes all the way down the uterus. And you know, that definitely could, if we put them in labor and we give them, you know, the medicine or whatever, it could cause a uterine rupture, depending on how weak the scar is on the uterus. Or again, uterine surgeries that there might be some type of scars or, you know, the tissue's affected. We don't want to cause a uterine rupture. Patient has placenta previa. That's okay. So the placenta usually implants somewhere up on the uterine wall around 2 o'clock, I guess you could say, if you're looking. It should be in an upper area. If it's low lying or it's, you know, down covering the cervix, it's previa. It's in front of where the baby would come out. That definitely would be a contraindication. We could not do this test because we could have some issues with the placenta, and the condition of the placenta can be affected, and of course that would definitely cause some issues for the baby. Or premature rupture of membranes. So the membranes is the water bag. If there was a break in the water bag prematurely, we definitely don't want to stir things up with contractions. And I mean, breaking the water in a patient that's ready to deliver is a form to help them jumpstart labor. Okay, we do that to help induce. Sometimes we'll rupture their membranes. So we don't want to cause any kind of contractions in a premature rupture membrane patient. So it's a patient that their water bag breaks early. We definitely don't want to put them in labor. All right, moving along. So not everybody is going to have this, but they can do an amniocentesis on a patient, okay? By obtaining amniotic fluid, they would insert this needle and they would use the transabdominal ultrasound as a guide to look to see where they want to go in, to get a good pocket of fluid. Because again, we're looking at the amniotic fluid, collecting the amniotic fluid. The uterus, we're looking at the uterus and trying to make sure it's up in the abdominal cavity to view it better so that we can look for that pocket of fluid. Who would have this done? If they had a prenatal diagnosis of genetic disorders. So like I said, not everyone is going to, want to have this done. But if they have a history of genetic problems or disorders in the family, they may want to have an amniocentesis. Some patients are like, I don't know and I don't care, whatever it is and whatever it might be, let it be, okay? But some are like, yeah, we had some issues and, we would definitely like to know if our baby is going to have some issues so we can mentally and physically prepare. We can also, so what kind of defects or congenital defects? So we're talking about possibly like your neural tube defects, spina bifida, or, any issues with, anything else that could be passed down genetically to put that baby at risk. But we could also, using that pocket of fluid, we can look and assess the pulmonary maturity. So patient comes in, she's in early labor, and, or she might be on the fence, like as far as prematurity. She could be like in her 36th week, okay? And we may want to just make sure that this baby's lungs are okay and what we're going to deal with if it does come, okay? So they'll do pulmonary maturity test, and where they'll take this fluid and they'll look for proteins to see the ratio of the proteins and to see if the baby's lungs are mature enough and if the baby can, sustain life. So that's another way or another reason we could do the amniocentesis. So it's not just for genetic testing, but also to see if there's enough, the protein present to determine if the baby's lungs are fully functioning. There's some complications involved. So with mom, she can have some amniotic fluid leakage. She can hemorrhage from the procedure. She can get an infection. She can get put in labor. She can go into labor. Damage to the intestines or the bladder. And then she could also have an amniotic fluid embolus, which could be very serious. So there are some things, also placental abruption. So the placenta can come off the wall of the uterine wall and abrupt, which would cause, some serious issues. And again, just a lot of things can happen. They would be at risk. So after this procedure, we're definitely going to watch our moms for a few hours and put them on a fetal monitor, making sure that they're okay. As far as the fetus, they can have hemorrhaging, they can get infected, they can have direct injury from the needle. So, that's why we have to use the ultrasound to guide to get where we need to go, because we don't want to stick the baby. And they can have premature issues. They can even have death involved. So, again, it's risky. Not everybody gets it. It's just on high-risk people or people that, are requesting it because of genetic disorders in the family. But amniocentesis, or like I said, we're looking at fetal lung maturity. So these are just some of the genetic disorders that, again, spina bifida, fetal lung maturity, Down syndrome is another, issue. And then the cleft lip, cleft palate, again, all those things that could be genetically passed down. All right, so the next test, this is called a chorionic villus procedure, or a CVS, you might hear me say. They go in and they're not taking fluid, they're going in and taking tissue. Okay, this is usually done between 10 to 12 weeks gestation. It's also used for genetic, metabolic, and DNA studies. This cannot detect neural tube defects. This is definitely something different. But again, I had a friend that was pregnant later in life, and she was like 40, and she wanted to have this done just to make sure that the baby was going to be okay and if there was any issues. So they did the CVS on her, and everything came back fine. Baby was healthy. But they're taking, like I said, tissue, and they're examining the tissue. So they're taking the outermost membrane, the chorion, is the fetal portion of the placenta, and that's where the sampling is coming from. And they're looking again for early genetic testing with the embryo. So not everybody is a candidate for this either. And it has to be, you have to have protocols, certain protocols, because it can be very risky as well. Genetic testing, well, this is just times that we would do it, and at 11 to 14 weeks, we can do a multiple marker screen where you'd have an ultrasound looking at the nuchal cord, nuchal translucency, where you're looking at the cord to see if it's translucent. We're looking at placental proteins with it. So 11, 14 weeks. So 15 to 20 weeks, we look at the MSAFP, maternal serum alpha fetoprotein. This is a quad screen. It's just, you don't have to like know this into depth, but I'm just telling you. It's a quad screen where we're looking at different values of and it's a blood test actually on mom. And they're looking for possible neural tube defects or chromosomal abnormalities. 18 to 24 weeks, usually they're doing the ultrasound, and they're looking at that for fetal anomalies. 24 to 28 weeks, RH type and screen. If the mom is negative, she should get some RhoGAM at 28 weeks. Okay, and she'll get it again if the baby is positive. See, at 28 weeks, we don't know the baby's blood type. We don't know if it's RH negative or positive. So we give it as a prophylactic, thing. So, but at birth, we definitely know if the baby is positive, because if the baby's positive and the mom is negative, mom needs to get some RhoGAM before she leaves within 72 hours of delivery, because the next pregnancy, mom's blood will build up antibodies to attack the baby's blood of the next pregnancy. And then also, we said at 28 weeks, the glucose screening for gestational diabetes, we're doing that. 35 to 37 weeks, we're checking for anemia, risk of hemorrhage, and then, like I said, at 36 weeks, they'll do that group E strep test if the doctor finds that is necessary on the patient. And again, if they test positive and they go into active labor, we need to be prepared to administer antibiotics. So genetic testing provides tools needed to determine the heredity component of many diseases, and it also improves the ability to predict susceptibility to disease. We can also get it when it's onset and progression, and even respond to it with certain medications if necessary. Genetics is currently a contributing factor in all human illnesses. In OB, genetics can occur prenatally. We look at prenatal stuff going on, and even, again, it just depends on how much. Actually, it's very costly. How much is involved, with the financial obligations. Again, those factors that can determine whether mom and dad want to do this, or if they decide to do genetic testing. It's a financial issue involved and lots of cost ramifications. And a lot of times insurance plans do not cover this. But I mean, if you continue to have issues with pregnancies, or you have issues with other previous pregnancies with genetic issues, this is something that people may want to consider. And there's also a lot of information out there, different websites and stuff that are provided, that parents can even just look into it to decide, if this is something that they would want to partake in. All right. So we're looking at genetic disease and how it affects the individuals, families, communities, and society. When we do genetic testing, that's what we're looking for. It's an analysis usually of the human DNA, RNA, chromosomes, and proteins to detect abnormalities related to an inherited condition. Genetic disease affects people of all ages, socioeconomic levels, racial and ethnic backgrounds as well. There is an impact of genetic disease on family and community regarding financial aspects, lifestyle alterations, cost of long-term care, physical health problems, coping with intolerant public attitudes, and social isolation. Again, these are all things that you need to think about if you're possibly going to have some genetic impaired, pregnancy issues. What can we do as nurses? We want to develop a plan of care that incorporates genetic assessment, identify genetic information, resources, and services specific to patients that we want to give to our patients. We want to identify ethical, cultural, legal, and fiscal issues related to genomics, facilitate referrals for specialized services. So if we do have a mom that does genetic testing and she finds out that there's going to be an issue, you want to be a resource for your patient. You want to provide them with as much information and resources that they can get their hands on. And of course, it's not just the patient. You're treating, family. It's a family thing. It's not just, dealing with just the baby. It's a family. So again, nurses are advocates in so many ways, and this is just another way that we can function as a patient advocate. All right. So genetic-related nursing activities, collecting, reporting, recording genetic information, these are just things that you would do, to help your patients and your clients. Offering genetic information and resources, this is kind of what I just had said in the last slide. Participating in informed consent process and facilitating informed decision-making. Remember, you never get a consent signed. That is definitely not your job. It is not your duty. You can witness a consent and make sure you're truly witnessing the consent. Don't just sign a paper and the doctor give it to you and say, yeah, I told the patient about this, she signed it. Go ahead and just witness. I didn't have a witness at the time. You do not want to sign your name to any document unless you were in the room, present, and you were there when it was, explained to the patient. And of course, you don't get a consent signed. If someone is having a procedure, and the person that's doing the procedure or organizing the procedure is the one that needs to inform the patient and determine whether they want to consent or not. This is also, we want to take into consideration care of families who have lost a child to a genetic condition. So they may not have had a child with a genetic condition that they're still living, but they might have lost. It could have been in utero. It could have been, after delivery. But again, we don't look at just the patient, but we're caring for the family. All right. Some more genetic key points. Genetic disease affects people of socioeconomic levels and racial and ethnic backgrounds. We just talked about that. They span in every clinical specialty, and again, it's very expensive. So things you got to, think about. Decisions are based on results. You got some parents that like I said, they just want to be prepared, and you got some that are, that are not, they're going to do something. They're going to be proactive. So as far as abortion, that would be something that would be depending on the results of the prenatal test. Patients can choose. That's up to them and whatever goes on with the doctor. They're going to consult with their HCP with either presumptive or positive results of congenital defects. If you're caring for a patient post-abortion, either spontaneous or elective, regular post-op care is provided. There's different laws governing abortion, and they vary from state to state. We're not going to go into abortion. We're not going to talk about abortion. It varies from state to state, so there's nothing just written in stone that is just over, just general abortion. For our purposes, this is not really going to be testable material, but I just wanted to put it out there that this might be one of the avenues that your patient would take in decision making depending on the results of the genetic testing. As far as assessment, we want to assess, it's ongoing assessment, the whole pregnancy. So general guidelines for prenatal visits, every 4 weeks for the first 28 to 32 weeks. You go for that initial, you go for the initial visit to, decide, I guess you could say just to make sure, yeah, you're pregnant. But every 4 weeks for the first 28 to 32 weeks. So from that point on, every 4 weeks until they're 28 to 32 weeks, okay? Then every 2 weeks and that would be through week 36. So every 2 weeks. So from 32 to 36 weeks, every 2 weeks. Then after week 36, every week until birth, until delivery. So is that written in stone? No. If you have somebody that has some issues, they're high risk, they might be seen on a different schedule. But this is what we usually do. This is our routine with our pregnant patients. But depending on their status, or if they're at preterm labor, or they had issues with genetic issues, or they're at high risk, they may be seen differently. Okay, it just depends on the status of the patient. They also may opt to see a special doctor who is a perinatologist, and they only see high-risk patients. So they might be, doing something completely different. But for your testing purposes, this is what, we usually do. With pregnancy, there's an understanding of pregnancy. We want to make sure that our patients are aware that there's going to be a lot of changes. We evaluate or we assess their attitudes and expectations, health teaching needs, especially our prima gravidas that have never been pregnant before. They don't know what to expect. Support is available if need be. And of course, knowledge of infant care, nutrition. There's so many classes that are offered now at hospitals. Wherever you're going to deliver, usually if you deliver at that facility, they're usually free of charge. But there's prenatal classes, there's Lamaze classes, there's C-section classes. If a patient knows she's going to have a C-section, they have a class that they can prepare her, for that and her family. We have kangaroo classes. That's for little ones that are expecting brothers or sisters. They're the big brother or big sister. We have grandparent classes even. So, we have classes not just for the mom. It used to just be for the mom, but now it's for the entire family. Depending on where you fall and where you want information, you can pretty much sign up for these classes. So implementation, nursing care of parents over 35, we want to take into consideration. You want to explain all planned testing procedures, including any special pre-testing directions, and obtain informed consents. You want to answer all the patient's questions, including those regarding why the tests are needed, what the test entails, when the results will be available, and the significance of the results. Protect the patient's privacy during testing. You know, some things are very invasive. You don't want to, expose your patient to having some issues with, being private. So you want it to be private. Support the client in whatever decision she and her family make. So even if it's something that you would definitely not decide to do, you have to be respectful of the patient and her choices. So, no matter what your personal feelings are, you have to put them on the back burner, and you just have to be very neutral and support your client. Demonstrate non-judgmental attitudes, again, and don't project your beliefs and feelings to the patient. So again, you don't want to have your own personal beliefs come in and affect the care that you're going to provide your patient. Okay. So, but knowing that over 35, there's risk of death that have declined dramatically because of, the testing. The birth rate for women, 35 to 39, 40 to 44, it's highest in more than 3 decades. Like I said, your patients are more career-oriented. They want to do other things before they want to have, babies in life. Women over 35 are more likely to have chronic medical conditions, so they're at risk because of that too, because after 35, sometimes your body seems like it's falling apart. Cesarean birth rate has increased, and there is risk of conceiving a child with Down syndrome, again, if they are going over 35. So there's always a lot of risk involved. But again, we have a lot of tests and things that we can prepare. And these are just, again, we want to identify concerns and promote strengths. We need to discuss risk with our patients, identify concerns, promote strengths. Couples who decide on amniocentesis or chorionic villi sampling, you want to provide information, answer questions, provide comfort, emotional support, protect their privacy, again, during testing, because it can be very invasive. Again, I will repeat, you do not get a consent signed by you providing the information for the procedure. That is, whoever's conducting the procedure or the physician in charge is the one that obtains a consent, okay? We can witness it, but we cannot collect a consent. So as far as evaluation, expected outcomes may include the client or partner are knowledgeable about the pregnancy, expectant couple and children, if any, are able to cope with pregnancy and future implications. Patient receives effective health care throughout the pregnancy, birth, and postpartum. Patient or the partner develop skills in childcare and parenting. Again, these are all things we want to evaluate, and these are expected outcomes that we might want to look for when we're caring for these patients. All right. And that conducts this lecture for prenatal testing or antepartum testing. If you have any questions, I know that this is, one of those online lectures for my regular class that meets because of a holiday. So if you have any questions and you're normally in class, or even if you have any questions and you're just watching this on the hybrid course, please feel free to email me. Again, look at what is posted under this lecture tab. You're responsible for the SLO ratings. Anything that's posted that can help you with this content is all testable information. So feel free to contact me if you need anything. It was a pleasure teaching you today, and have a good rest of your day.